Patricia Vandergrift. She is first a nurse of women and infants health for the last 30 years. She's a neonatal nurse practitioner and the Care Always Palliative Care Coordinator at Neonatal Health and at Wake Forest University Brenner Children's Hospital. She received her doctorate degree from the University of South Alabama and previously attended Duke University and the University of North Carolina. As a former faculty member, she stays committed to education and nurturing the next generation of nurses and physicians through regional, national, and international presentations, as well as precepting new nurse practitioner students and residents. In addition to her career, she is an avid outdoorsy person. She relishes in adventures such as deep woods backpacking, carrying a 30-pound backpack, and hiking 8 to 10 miles a day. Wow. And hiking on North Carolina greenways, traveling the USA, and gardening. She is deeply loved and spoiled by her family. 1 husband, 2 biological sons, 2 male cats, 1 female dog, and all male fish, she assumes.
Yes.
Thank you, Dr. Vandergrift.
Thank you. Can everybody hear me okay? They have me mic'd up here, but do you need me to be at this mic? I'm pretty loud, so I just want to make sure everybody can hear me. I'm play with this pointer here for a second because usually I mess it up. Okay, so I have been assigned today to do pain in neonates. I am a palliative care specialist. I also am a developmental care specialist as well by nature. Developmental care is like one of my favorite things. Today we're not going to talk about NES because you've already had that, and we're not going to talk about end-of-life pain. But if you have questions about that, we can talk about it. But I did not go there because I get to be the person that gives you pain before lunch. So I want you to have an enjoyable before lunch experience. So we're going to talk about pain in neonates. A lot of this is going to be refresher stuff. You already know it. It's just good to be remembering it because it's very much in the literature and it's very much on Joint Commission's mind when they walk through your doors. I do not have any conflicts of interest to declare. Our objectives for today is we're going to define what neonatal pain is, what are the common causes of neonatal pain, what some signs and symptoms of them are, what is neurological protection, how does that affect our developing brain, our pain assessment scales, which that'll be very much review for everybody, and then strategies of how to handle and alleviate pain in the neonate. If you printed slides, I sent them off weeks ago, so my lecture today is a little bit different from your slides, but that's after reviewing last night when I got home from work. So what is the definition of pain? If you go in the literature, it'll tell you it's an unpleasant sensation. It's also, Joint Commission says it's whatever the patient says it is, wherever it's located, whenever it happens. So it's really patient-focused. What we do know about babies is they're nonverbal. So they can't tell us verbally when they have pain, but they do show us signs and symptoms of their pain. And this little man is probably getting hungry like you all. So why do we identify pain? Well, Joint Commission, the one that helps us to be able to, you hear better over here? Okay, all right. Now my husband would argue that I am very loud, but I can't hit the back, so I got something on him today. So it is a 5th vital sign. When you do all your vital signs on your babies and on your patients, number 5 should be a pain assessment, and they're going to be looking for that when they come and assess your facilities. It also is a warning sign of what's going on with the body. Is there any actual or potential cell damage going on? And pain is one of those indicators that there is things going on with our body. So what do we know with our littlest patient's pain? We know that baby's pain is very complex and multifaceted. It shows up in a variety of different ways. It can be sometimes under-recognized or unrecognized when we do our assessments. Often, it's very untreated. A lot of people will say, well, let's try some non-pharmacological things to see if we can get the baby to respond better. What we do know is poorly treated pain causes babies to kind of go like a 180, and they become more hypersensitive to pain. So the less we treat them and take care of their pain, the more their brain adapts to the fact that we're not going to take care of them, and they become hypersensitive. And I often wonder that when I take care of preemies and we suction them, when they go to the dentist later in life, does that cause disturbance in their brain? Because it does me when I suction them. I often wonder, do they have that memory of how that is a painful situation for them? So what we do know about neonatal pain is somewhere between 16 and 18 weeks gestational age, and they've done studies on this, that fetuses actually can recognize pain. Even though we have an absence of the signs and symptoms, it doesn't mean there's not pain present. And what we have found, and literature continues to show as research continues, is as babies experience pain, it rewires their brain. And we'll talk about that in a little bit, of how that happens and why that happens and how that long-term affects these children. Literature also, if you go into the literature and they talk to the parents after they leave the NICU, one of their biggest fears is their baby has experienced pain. Up to about 89% of them have on surveys said that their child has experienced a lot or a great deal of pain, especially of those children facing into life situations. What we do know also from their reports is that witnessing their child have pain causes long-term effects on them. It causes them a lot of distress. And it can cause them to hit what we call a complicated grief, to where it becomes more pathological grief for families, especially if they can't see that the pain is being treated appropriately and their babies get relief from our care. So there's a variety of pain sources, and a lot of this we talked about is a review, but it's good review. So somatic is the rise of pain that hits the spinal ganglia and the nerves in the spinal column. It's a conducted impulse of pain. It's a constant or localized pain, so those are its characteristics. Some of the organs or body parts that are affected, superficially it's the skin. Deep, it's the muscles, the bones, the tendons, the ligaments, and the blood vessels. So when we think about a 22-weeker that we're starting to resuscitate, and for other facilities, 23 or 24-weekers, those babies have gelatinous skin. So they are at risk of having somatic pain for those first 2 weeks until their skin thickens and gets tough like ours. When we poke them, when we do things to their skin, when we turn them, when we change their diaper, it can cause this impulse into their spinal nerves and cause them pain. Deep muscle-wise, you think about those shoulder dystocias that get all stuck in there and then they come out and their arms just aren't working right, and we've stretched those ligaments and tendons, and how painful it is when I'm a gardener, when I am close to 50, go out in the yard and garden, I have muscles that kill me that I should not have muscles hurting that bad. And I think about those babies that have shoulder dystocias, of how their arms are twisted and trying so hard to get them out in a safe method, that all those tendons and ligaments cause them pain, and it hits that spinal cord and it gives this impulse of constant but localized pain. Another pain source is the visceral pain. So it's injury to our internal organs. And if anybody's ever had surgery or anybody's ever had an appendectomy or gallbladder issues, what you do know is that's a very deep, intense, dull ache when you have those pains in your body. It's diffused as well. So I have my gallbladder. I don't know if anybody else has. When I first was having gallbladder issues, I thought I was having a heart attack. The pain diffused way up here into my shoulder blades. So it's a very diffuse pain. So your baby may be having belly pain, but it diffuses up near its upper half of its body. And when you go to touch them up there, you find, oh gosh, why are they so sensitive up there when their belly's so big down here? It's also described as cramping or a steady pain. And it's most commonly found when our organs distend. So with those kids that have necrolizing enterocolitis, they have neck, and their bellies get big and distended and round and shiny, you're dealing with a visceral pain. Hyperinflation of lungs. Lungs are an organ. So you think about those babies that we put on the jet ventilator, the oscillator, and we get that x-ray and their 11.5 ribs expanded. Visceral pain. Neuropathic pain is the damage to the peripheral or the CNS nerves. So that happens a lot with our babies that are experiencing HIE, or they're having seizures, or something that's a disturbance in their brain. We have quite a few. Dr. Wynn talked about a few of our genetic differences. But babies that have those genetic differences that affect brains, like schizencephaly, lissencephaly, they're at potential for this neuropathic pain. It's described as an abnormal sensation with burning, tingling, numbness, stabbing, shooting, and unpleasant touch. So if you've ever taken care of a baby that's been affected by a neurological condition, when you touch them, sometimes they just become very unglued. They can't handle just simple touch and containment because it sends those nerves into hypersensitive mode, and it causes them pain. Bone pain, for those that have ever known people that have experienced osteomyelitis or fractures, or people that have had bone cancer, describe that as just such a high, intense pain, as well as being very dull, but a continuous kind of pain to their body. It affects their skeleton, mostly their thoracic and lumbar areas. It innervates all of their sensory nerves. So even dependent upon if it was something up in their upper arm, it's going to attack those nerves that go up and down our sensory of our spinal cord. Questions about that? Lots of different pain. New ways to describe it when you care for your babies. So when you're doing your notes, you could throw that in, and boy, you look super intelligent. Causes of pain. So we kind of already talked about this. Skin breakdown. Skin does not really get tough for the first 2 weeks after birth. Sepsis. If anybody's ever had a urinary tract infection, that is just, you feel like you're dying. That's not very comfortable. Upper respiratory infections. All of us at some point have had an upper respiratory infection, and it just, you feel like you've been beaten. Neck. GERD. Those that take care of preemies, babies that have GERD and have that constant reflux going on, they are just irritable and miserable and act like everything that's happening to them is painful. Genetic differences. A lot of our trisomies, a lot of our babies with abnormal head ultrasounds, they have the causes of pain. When babies get tired and fatigued during their the super preemies, during their touch times, you can see that they get antsy, that they start having that hypersensitivity to touch, and they get overloaded. I had a colicky child for 6 months, and boy, there was no doubt in my mind my child was in pain from 6 p.m. to midnight for 6 months of his life. Neurological immaturity plays a factor in their pain. Immunizations, as parents, if anybody's ever had to hold their child for immunizations, you know that causes them a lot of pain, and they just want snuggle time afterward. A lot of the things we do, heel sticks, IVs, needle aspirations, dressing changes, intubations. A lot of times as caregivers we forget that intubations can cause pain, and that pain relief is needed prior to doing that if possible. And then chronic stress of being born early, being in an artificial womb, trying to be in an environment that's not your mommy, and not having those things that help soothe babies, such as mom's amniotic fluid, mother's voice, the things that keep them calm. So what are consequences of pain? Through research and literature, they have done numerous studies. Julie kind of talked about a few with aromatherapy, essential oils. Consequences of pain is that we find babies can have increased cortisol levels, a stress indicator showing us that their stress is elevated. They also have decreased immune function. So when they're stressed, they're already immune compromised. It is more pronounced in babies that have compromised immunity. When they're stressed and they're having a great deal of pain, that can decrease and cause them to be sick. Decreased neuroplasticity, we're going to talk about that in a minute. It's the stretching of our brain, the growth of our brain. And in babies, we definitely want their brains to grow. We want to grow some pretty smart human beings. Impaired learning and memory, and we'll talk about the brain alterations in a minute. But both these little babies, look, they don't feel good. They're doing look at the slides and look at the pictures, because we'll be talking about some of these in a minute. So signs and symptoms of pain. As you can see on this little slide, this baby has a furrowed brow, very furrowed, looks angry. Their nose kind of gets turned up, and it almost gets bulbous when they start crying. Their mouth is usually open. They get those really deep nasal labial folds. We also see some subtle changes and sometimes pronounced changes. We see changes in baseline of our vital signs. We see tachycardia, bradycardia, sometimes hypotension, sometimes hypertension, tachypnea. As babies continue to have pain and get more and more stressed, sometimes we'll see those apneic spells, gasping, agonal breathing. Sorry, that one kind of slunched over. Increasing of retractions. In the older children, sometimes we'll see sweating and decrease of their oxygen saturations. Their colors can change. Sometimes they're bright red. And mostly with our really immature preemies, we start seeing that pallor and that cyanosis, sometimes that gray undertone. Grimacing and crying, the restlessness, the hyper alert state. They can't get consoled. They just really are antsy. Sometimes when you're taking care of these babies, you'll go in their bed and it's almost like they have bugs on them. They just can't get settled, or you poked them with a hot poker. They're just miserable. And then if it continues on, or as the baby progresses with their illness, sometimes we see that lethargy or that withdrawal to where they really separate, and you pull up that little blanket and you're like, ooh, this isn't good. Baby's not looking anything like he used to look. Definitely having signs and symptoms possibly of pain. And with older children and some of our other children, a lot with our NAS, we see that stiff, rigid, extremities straight out, can't bend them, you can't get them tucked in to hold them. And the flaccid can be along with the lethargy. Anybody see anything different than those signs and symptoms ever? So a whole slide of babies that are angry. I didn't have any of babies just laying there, but we've all seen that where they just kind of lay there. They're not even flexed in any position, but very similar. They got those little eyebrows wrinkled up, mouths wide open, their little nose gets all bulbous. You can see all their little nasal labial folds. They all look like it's time to eat. So what is neuroprotection? We talk about this a lot. Jody, one of our physical therapists, she talks about it a lot as we lecture our staff on how to best care for our babies developmentally. It's interventions that are used to promote and support developing brains, making sure that we're minimizing stress, minimizing the pain that babies experience. Why are we doing this? Because a lot of us out there in the community are taking care of 23-weekers who are born with a super smooth brain. They don't have a lot of those deep grooves. They've not had the migration of their neurons yet. So when they're born, their brain is really smooth and they have a lot of growth to happen. What we do want to do is get them over to the 37-week brain, those term brains, to where we have more of the grooves and we have the migration of their neurons, and we know that the inside to the outside of their brain is forming. Making smart human beings. We need a good president. Fetal brains. What we do know about fetal brains is they continue to grow to the 3rd trimester. All neurons are present, they're just not organized yet by the 3rd trimester. We are born with millions of neurons, more than we will ever use. And this is a really nice cartoon of what happens with our brain. The last 6 weeks of gestation has the highest rate of brain organization. It's when babies are able to pull things together and get ready to be on the outside. And we see that with our late pretermers. They're easily trying to be big people. They have a couple of little things going on sometimes, but they're trying to be big. They're trying to be organized. They're trying to do those things, suck, swallow, and breathe without choking. They're trying to remember to breathe without needing caffeine. So the last 6 weeks has the highest rate of getting everything together for them. Volpe, he's one of the neurodoctors of the world. If you ever do any research on neurology, he's the one that has the most quotes. He describes it as any actively developing event is highly vulnerable to insult. So when the brain is developing at this high rate, when babies are in that growth state of 22 to 34 weeks, they have the biggest growth of their brains. They have the most activity and the most capillary expansion during that time, that any insult that happens to them, birth, premature birth, IVH, having an inner hemorrhage of their brain, having seizures, anything of that can cause an insult that can be a long-term devastating effect on their little brain. So as you can see, at 36 weeks, they have quite limited amounts of neurons. And as they're getting more into the newborn area of being less than 28 days old, they're getting more. 3 months, they're getting more. And about 6 months to 2 years old, we have the most neurons activated and ready. And you'll see that if you have children. That 6 months of age to about 2.5 is so explosive with new learning activities every day. It's just wonderful. New words, new ways that they've discovered the world, all those why questions, all those things that they want to be inquisitive about. And then, if you don't use it, you start to lose it. So somewhere around 4 to 6 years of age, we start pruning our trees in our brain, and we start losing those neuron connections. What we do know about babies that have insults, since we're born with more than we ever use, we're hoping, and I think they're starting to discover it more and more as they go and discover new things about our bodies, is that we can make new connections that will help children to be able to adapt better. I think mine got a little pruned earlier than 6 years sometimes. So what is neuroplasticity? It's the ability of the brain to make short and long-term modifications. So if there's been an injury or a baby's been exposed to being born early, it's the ability of the brain to start to stretch and strengthen their neuron connections in hopes to adapt to the world outside. So what we do know is when babies are born too soon, their brains are altered. They have immaturity of their organization of their neurons. They have adaptation patterns of how their neurons are stacking up. So when we are in our mom, neurons start at the middle and should migrate outward like that 23-week brain. Nice and smooth, and as it migrates out, it makes all those nice deep grooves in our brain. Preemies start to have those factors altered. So it can make them have more disorganization, more of those. You see the coordination if anybody does developmental clinic after babies go home, we're assessing to see how is their organization. Are they able to do those tasks of block stacking and putting rings on the little tube? And can babies bring their hands midline, which is a good indicator of good brain development? So why is it so important to protect the brain? So pain can cause, we talked about, a lot of effects on the brain. It causes damage to the neurons. What we do know is babies that have had extensive pain exposure are at a high risk of having an intracranial bleed. And bleeds, depending on where they are in gestation, what we know is those germinal matrix bleeds are at the highest risk for that watershed somewhere between 18 weeks and 30 weeks gestation. And we have a lot of babies born in between that time frame where their brain is trying to be formed and be stabilized. And because of that increased amount of capillaries in there in that watershed area that helps us grow our brains outward, we're at a high risk of having these bleeds to our babies. The disabilities, and this is a pretty significant bleed, this probably was one of the causes of this baby's death. You can see that the blood on the outside of the brain tissue is pretty extensive. What we do know is when blood is on brain tissue, it destroys it. And from there, it will form water-filled cysts in that area that the brain tissue should have been. And the types of disabilities that go along with that are mental disabilities, so IQ disabilities, blindness, deafness, cerebral palsy, being unable to stay on task in school, having attention deficit. Autism spectrum is being associated with some of these bleeds as well. And what we do know is to be able to have that neuroprotection and that neuroplasticity, babies have a right to be pain-free. That'll be one of the things that when Joint Commission comes in your facility, they're looking to see how do you make sure babies stay pain-free. And it's by your assessment skills, when you're at that bedside, when you're taking care of these children, paying attention to those subtle changes. Listening to the parents. Moms and dads know their babies better than any of us. We all think we're surrogate parents in the NICU. We all think we know the babies better than any parent. But parents really know those subtle signs of their babies. And then providing those comfortable, soothing aspects of care, the non-pharmacological and the pharmacological measures that we can intervene with to keep them pain-free. So what do we do to provide relief for our smallest patients? That baby's a little bigger than some of the ones we see. What's required, and everybody hates this, especially as we do EPIC and we do Cerner and we do all these different programs. The pain assessment is put in there, and then we're told over and over, you need to reassess. You need to reassess. In 30 minutes, in an hour, you need to reassess. But it's making sure that that baby's adequately being captured. Do we need to titrate upward on medications or any of our other methods of giving them comfort to provide them pain relief, decrease their anxiety, and cause less suffering to them? We have 1 million pain pediatric assessments out there. I think there's about 30 when I went in the literature. I think there's about 30 of them available. And what the ones that we use in the world of neonates is always behavioral assessments. When we get into pediatrics, when we go to PICU, we have the face one. Everybody has the little faces on their badge and say, what's your face look like? But with babies, we have to look at their behavioral. What is going on with their body? What does their body look like? What are they showing us with those subtle signs? Almost all of the 30 that are out there have been validated and show reliability when used. And they're all for the preverbal infants. And these are probably some of the top ones that I have found, and I've worked at quite a few NICUs across North Carolina and Illinois. And there's quite a few of them out there, and they'll look for heart rate, what their saturations are, what their face looks like, what their body language is doing. Are they crying? What's their breathing patterns? What's their arms and legs doing? I'm trying to see if everybody's pretty much the same. Vital signs. I think that's everything. And then we scale it. Is there anybody using a different scale out there that's not up on this board? No? These are pretty much it. I work at 2 different facilities. Well, I work at 3 different facilities currently, and each of them uses a different scale. None of them use the same one. But each of them assess well, and we can score well. So what are strategies for pain management? Ultimately, what your goal is to have a baby that looks like this. All snuggly, all content, getting some good deep sleep, good color. Can we do this without medications? Yes. As a developmental person, the best thing is when we can capture pain without medicine. That's awesome. We're doing the brain a service by not giving chemicals to a baby. That's not even supposed to be here yet. So non-pharmacological support is awesome if we can provide it. The positioning, swaddling. We have Zachy arms available. We have snugglies to get babies in their little boundaries. We have now the halo sacks to keep them in their boundaries as well. Massage therapy is one of our big things that we like to use at one of the facilities I work, to give babies that relaxation, just to get in those deep muscles and get them relaxed. Rocking and rhythmic soothing. There's many different forms of that. That comes in those bouncy swings, there's beds available. The heartbeat sounds, I don't know if everybody that's working out here in the audience, if you have those heartbeat sound machines on babies' beds, how those are like the best thing in the world. And you beg your managers to get you batteries because you don't ever want to run out of batteries for them. Pacifiers and sucrose. Sucrose is wonderful for pain relief. Breastfeeding. You'll see moms, and there's been more and more studies out there of moms that put babies to breast, and they do the heel sticks of how decrease the amount of pain exposure there is. Involving parents early with anything we do to provide comfort when we're doing a painful activity to the baby is really important. Doing kangaroo care, how essential is that to get those babies in that deep sleep and they're in that comfort zone with their parents, the protectors, the people that are going to care for them. And I love that little picture of the little boy holding his sibling. I just think that's so sweet. If you go on YouTube, and I have teenage kids that are always on YouTube, and you know, they're like, Mom, you gotta watch this video and all that. Well, there's a lot of videos out there about this 5 S's. And there's actually some really fun ones out there. I was scared that if I put videos on here, it wouldn't connect as well, so I didn't share them with you. But you can go on YouTube and find them. And the 5 S's are for those happiest babies. What they found is the swaddling is that security, the shushing noise, and these are hilarious. They're mostly of men shushing at their children, going shh, and it's that white noise. It's like turning on a white noise machine. The swinging provides that rhythmic, just like in the mom, artificial womb of walking around like a mommy. Sucking provides that soothing, that non-nutritive suck. And skin-to-skin connection, that warmth, the heartbeat, hearing the muffled voices. So 5 things to help. For anyone that's out there pregnant, these are wonderful to know, especially if you end up with a colicky child. It's also great for grandparents and anybody else that takes care of these little babies. Interventions. This one on the top left is called the robot. This is a newly developed bed. It goes in all of our isolettes. It fits in giraffes, it fits in the Dragers, it fits in all of the beds available. And what this platform does is it kind of rises slowly and then kind of creeps back out and goes down. And in the meanwhile, you can infuse music through it underneath, or you can infuse the mother's heartbeat. Just like with Build-A-Bear, how we can give them those little Build-A-Bear inserts and you can capture a heartbeat, so they can listen to their mommy's heartbeat as well. The skin, the blue covering, is like skin. So it's very much like our skin. So when babies lay on it, they think that they're on their moms. And it also provides warmth for them. So it's just a really neat new product out there. Infant massage just really gets them in that deep, relaxed state. And then swaddling, it's always good to remember that babies want their hands midline. It's for brain development as well. So getting their hands midline to where they can suck and get that soothing from sucking on their hands is important. Pharmacological. Any questions about non-pharmacological? I'm sure everybody's using that out there. So pharmacological is going to require you to do an assessment and a reassessment. If you're giving medicine, you got to make sure you're assessing and reassessing. There are non-narcotic, and then there's narcotics out there. And what they do is they help reduce the symptoms and they help calm the pain receptors. They kind of dampen those pain receptors to keep them in a state of happy. Oxygen can be used for air hunger, and we use that a lot at end of life just to keep babies not necessarily alive, but to keep them comfortable so they're not agonal breathing and gasping for breath. Guidance with medicine. So always, always try your non-pharmacological means first. It's always great if you can get away from putting chemicals in a little baby. And you're trying to reduce those symptoms by reassessment. Do I need to titrate upward? How quickly do I need to titrate upward? Preferably, it's best to use the non-invasive routes first. PO, rectal, intranasal, and then IV mode. And escalating pain definitely needs to be captured. So if your pain scores are continuing to go upward, even though you're giving your medicine, then you definitely want to seek out your provider to increase your dose. Sucrose. There has been a lot of information on sucrose, and it's had good findings of being able to relieve baby's pain. It's a PO You can put it right in the mouth, under the tongue. Babies usually like their pacifier when you give it to them. It provides that mild comfort. The duration of it, though, is not very long. You'll find you'll give them a little squirt, and 10 minutes later, they're ready for another little squirt. They get addicted to their sugar. Tylenol or acetaminophen is a great mild to moderate pain relief. We use that a lot with our circumcisions, our babies that have fever. It's a fever reducer as well. It's a nice mode for our children that aren't having a lot of pain. You can give it PO, you can give it rectal. It's non-narcotic. It lasts for about 3 to 11 hours. The one thing about Tylenol is you have to make sure your liver function is working properly because it gets metabolized in your liver. And if we give too much, it can cause toxicity. Morphine. A lot of us are using morphine as one of our pain relievers. It's great because it comes in a variety of different routes. We can do it PO, we can do it IV. And when we give it IV, it's usually in very small allotments, so you don't have to give a whole bunch of fluid to your baby. It's great for acute, moderate to severe pain relief. It helps get your score down pretty quickly. It gives a sedative on top of pain relief. It's a vasodilator. It's very helpful with helping with our air hunger and decreasing secretions sometimes. It's very baby dependent. It has a half-life about 10 to 18 hours, so it's pretty long lasting. But the thing about it is it can cause respiratory depression if given in too much. And then it also can cause our hypotension, which we start battling sometimes when we start giving these narcotics. Fentanyl, I think, is one of our go-to for our itty bits and the babies that are surgical and are in need of having excellent pain relief. Comes intranasally, and I would suggest if you've never given intranasal narcotics, they're a wonderful mode of route of giving medicine that's very non-invasive, and it works very quickly because we have such capillary beds in our head, and so it gets into the system quickly. It's for acute moderate to severe pain. It's a synthetic opioid, so 50 to 100 times stronger than morphine. It gives good anesthesia effects. It also is sedative, and it also provides good pain relief. Once again, it's vasodilator, decreases our air hunger, and it penetrates the CNS very quickly. The only thing about fentanyl is it's a very short half-life. It doesn't last very long for our little people. And also, if you give it IV push and you give it too fast, you can end up with chest wall rigidity, which is never fun for anybody that's experienced that. Methadone is more for our NAS babies, but we do use it for our long-term babies that have become dependent on pain relief, those surgical infants. Sometimes we'll do methadone, we'll do different patches or oral medications for them. It's a long-term narcotic. It's great for our NASs, and some facilities are starting to branch out on their methadone use and use other means. It's also good for our opiate dependency. It can cause that QT prolongation. So sometimes we find that with methadone, we have to get EKGs because our babies are doing strange things on their monitor. The half-life is about 16 to 25 hours. Gabapentin. Not a lot of facilities use this. I left a couple of different narcotics out there. Some places use Precedex. That's also a really good narcotic out there. Has good effects on the brain, and it also doesn't change the brain tissue, is what they have found with Precedex. Dilaudid is sometimes used with our very sick surgical babies as well. I left those off because not a lot of facilities use those. Gabapentin is a really interesting drug, and a lot of people don't use it because they forget about it, that it's a great thing. It's great for that neuropathic kind of pain. So those babies that suffer from severe seizures, epilepsy, HIE, and you just see that just touching them sends them over the edge. This is a nice calming medication that helps relieve their irritability. And we give it a lot for the babies that we've ramped up all kinds of pain medicine and they still have these neurological signs and symptoms. And we'll give it to them and within a few days we'll say, wow, that really is helping them. So it's something for your back pocket in case you have any of those kids that you care for. So a bunch of our practitioners and leaders at one of the places I work went to the NEO conference this year. Did anybody go down to Florida this year to the NEO conference? It's usually in February. And because of some of the literature out there from 2016 to 2018, we're starting to change some of our practices of how we give medications because they're finding that giving narcotics can change brains and it can actually cause harm. So some of these, and if you want the references to them, I'm happy to share these with you. But what they found is that when we have too much opioid doses given and it has a cumulative effect, that there's an association with worsening cognitive scores at 20 months. So some facilities are really kind of snubbing their nose at giving too much medicine if we don't need it. Higher cumulative effects of fentanyl in premature babies have a greater incidence of that cerebellar injury. And it also has a smaller brain size. So when they're doing autopsies on those kids or if they're doing follow-ups in clinic, what they're finding is their brain size, their head size is smaller than average. Fentanyl influences infants' development in their eye and hand coordination. So long-term use of it, they've noticed during their scoring in the developmental clinic that they're having a harder time building their blocks, bringing their hands midline. And then Versed has really become one of those drugs that we're kind of veering away from as well, is that with Versed exposure and long-term exposure, there's been association with alterations of the structure of the brain, the hippocampus development, and then poor outcomes on their scores, so that if you start seeing changes with your providers ordering medicine, it could be because of some of these different studies out there. So in summary, it's essential for us to be assessing and reassessing and making sure that pain is brought to a minimal for these babies, that we're protecting their brains at all costs, that we're trying those non-essential pharmacological measures first, and that babies are entitled to not have pain and they should be pain-free. This is my 25-week niece. She just went home. She is a Tar Heel through and through, and she, at 25 weeks, went home with no oxygen, no pain at 130 days. And then these are my babies. They give me pain though. I have all kinds of little scratches on me. These are my two babies, Charlie and Hobbs. Questions? Anybody got questions? Everybody ready for lunch? Well, thank you. Enjoy the rest of the day. Yes? Go ahead. Well, let me get back to my microphone. I can.
Can you repeat the question?
Yes. So the question was, moms that are breastfeeding and they are have a dependence on methadone as well, and they're taking methadone, how long do we recommend breastfeeding, and how long will that affect the baby? Will they go through withdrawal later? What we have found is that it's for advantageous reasons, it's best to allow moms to breastfeed and get as close to that 2-year mark that the amount of methadone that is going through the breast milk is low enough and safe enough that it keeps the baby in a steady state, that long-term effects should not be a problem for them as much as if you just abruptly stop breastfeeding, of seeing that withdrawal. But as we've seen moms breastfeed and then stop pumping and stop giving breast milk, we do see a withdrawal period during that time frame, but we're able usually, because we're giving babies other modes of medicine as well, we're able to capture them, but the timing of how long that affects them is very dependent on how much that mom's been breastfeeding, how much milk she's been providing, and how effective that baby's been at breast. Does that answer that? Okay. Any other questions? All right, enjoy your Hickory lunch. This is the best place to eat.
Thank you, Dr. Vandergrift.
Thank you. Thank you.
We'll start back at 1 o'clock, so enjoy your lunch.